in 2017 World Workshop, we had the new classification. And even if you don't know this classification, this is an aggressive periodontitis in an old classification. And for the new classification, it is stage 3 grade C periodontitis. And once we are going to discuss if you are going to perform an immediate implant for number 12, we have huge educational problem in terms of clinical application. And if you apply implants for this case, and if you fail, and if you extract number 11 and also number 13 is, and I think, not an educational problem. I think it's a problem for all of us in terms of dignity of our profession. And I think we should apply the principles based upon the indications, and of course, not to apply any reconstructive or regenerative attempts into the diseased sites. I think this is so clear. And once we come back to this problem, you have the implant for the number 21, but you have already the pocketing formation of the 12 millimeter for this case. In this case, when we had the anamnesis, he had 2 packs of cigarette. First, if you're going to treat these type of cases, you should adjust and modify the conditions of the patient, of course. And he quit, he stopped smoking. And after this, he lost, of course, the remaining laterals. I applied step 1 and 2 periodontal therapy, and we ended up with this huge vertical hard and soft tissue defect. And now we are going to discuss, should we close the pocket first and then apply the vertical GBR, or we should perform it simultaneously? I think once we are going to apply our surgical principles, and if all the defects belonging to the same site, maybe in one surgery, we may work to solve all of these problems into one surgical session. So you can see the papilla preservation flap and exposing the defect. And when we come back, you can see the extent of the vertical hard tissue defect. You can clearly see with the periodontal probe measurements. And after this, you are going to apply your regenerative strategies. You can use titanium reinforced PTFE membrane. You can also use some of the screw to give a tenting effect. You're going to mix your xenograft with the autogenous bone. And if you are allowed, you can use also, instead of using a xenograft, in some countries, allograft is also provided. You may mix your allograft with the autogenous bone, and then you can cover with a non-resorbable barrier in these conditions. After securing the membrane with the screws, now it is time to think about supracrestal attachment. And in that aspect, you're going to apply enamel matrix derivative to support the attachment formation on the supracrestal portion. And now you are done. You're coming back to your original problem, which was the 12 millimeter of pocketing around number 12. And also you have some deep pockets on the adjacent neighboring teeth. So with the periosteal releasing, we are going to obtain a primary wound closure and should be maintained over time. And we are going to reach to the site after 1 year. And since we have a lack of space, I am going to apply only 1 implant to number 21, and I am going to use a cantilever to support the lateral missing incisor. I'm going to place the implant, of course, with respect to the manufacturer recommendation, with getting a primary stability. And we should not forget to improve the soft tissue conditions by adding the connective tissue graft. But to me, the most important and critical part is to achieve a pocket closure for this particularly challenging case. So you can see pocket closure is obtained and patient had a low smile line, so aesthetic point of view, we don't have any issues to cover.